Assalamu alaikum. Our topic for today is going to be cancer of the upper GI. We are going to cover esophageal cancer, gastric cancer, and pancreatic cancer. Esophageal cancer. Esophagus extends from cricopharyngeal sphincter to gastroesophageal junction or GE junction. Esophagus is divided into three parts. The first part is the cervical esophagus, second, upper and mid thoracic esophagus, and the third is thoracic or thoracoabdominal or distal esophagus. GE junction cancer. Is it an esophageal or gastric cancer? By definition, any tumor with an epicenter within 2 centimeters or less into the proximal stomach is considered esophageal cancer. And any tumor with an epicenter of more than 2 centimeters into the proximal stomach is considered gastric cancer. But anyway, GE junction and proximal gastric cancer or cancer of the chorea are treated as esophageal cancers, and we see that later. Incidence of esophageal cancer is highest in southern, northern, eastern Africa, and eastern Asia. There are two types of esophageal cancer: squamous cell carcinoma, which is the most common type of esophageal cancer, and it is known to be the highest in what is called the esophageal cancer belt, which includes northern Iran, Central Asia, northern and central China. The other type is adenocarcinoma, which is a disease of the distal esophagus and the GE junction. Its incidence is increasing, especially in the Western countries. For example, more than 60% of esophageal cancer nowadays in the United States is adenocarcinoma. Risk factors for esophageal cancer: the synergistic effect of alcohol and tobacco leads the risk for esophageal cancer, specifically squamous cell carcinoma. Lower socioeconomic status and poor nutrition due to low fruits and vegetables, as well as drinking beverages at high temperatures. N-nitrosamine used to preserve meat, Barrett esophagus, GERD, obesity, risk factor for adenocarcinoma. Tylosis, hyperkeratosis in hands and feet, including the inherited type of tylosis, Howell-Evans syndrome. Esophageal disease associated with chronic iron deficiency anemia in the US is called Plummer-Vinson syndrome. In England, it's called Peterson-Brown-Kelly syndrome. Achalasia, hereditary hematomas such as Cowden syndrome. Presentation. The most specific symptom for esophageal cancer, of course, is dysphagia. Also, patient may present with weight loss, cough or hoarseness of voice, could be related to tracheobronchial fistula, retrosternal discomfort and burning sensation, blood loss, melena, or hematemesis as a cause for iron deficiency anemia. 50 to 80% of patients may present with unresectable or metastatic disease. In case of pleural effusion and ascites, patient may present with respiratory symptoms or abdominal symptoms due to ascites. metastasis to liver, lung, and bones, cause symptoms related to these organs. Diagnosis. Barium X-rays is not used nowadays that much. However, it has value in demonstrating the extent of the disease and the degree of blockage. EGD is the gold standard test for esophageal cancer. In an early stage, the tumor may look like a superficial plaques, nodules, or ulceration. In advanced stages, strictures, ulcerated masses, circumferential masses, large ulceration. Of course, EGD give us the opportunity of taking biopsy, and usually we like the endoscopist to perform a deep biopsy, which is essential for accurate staging. So it is not just about finding cancer cells, it's about the depth of the cancer in the wall of the esophagus for accurate staging. Nowadays, EUS, endoscopic ultrasound, plays crucial role in diagnosis and staging. For T staging or tumor staging, EUS has a sensitivity of 81 to 92%, specificity 94 to 97%. For lymph node metastasis, the accuracy is 70 to 80%, and it increased significantly if it's combined with FNA biopsy. Of course, we take biopsy during EUS to confirm the diagnosis. Pathology. Adenocarcinoma, typically in the distal esophagus or the GA junction. For adenocarcinoma, we like to perform those tests for HER2, MMR, mismatch repair, and MSI, as well as PD-L1 for therapeutic reasons. Squamous cell carcinoma, this is in the proximal two-thirds of the esophagus. Again, we like to perform MMR, MSI, and PD-L1, but not HER2. HER2 is mainly is specifically for adenocarcinoma. All this has therapeutic impacts. Rare types of cancer: mucoepidermoid carcinoma, small cell carcinoma, sarcoma, adenoid cystic leiomyosarcoma, and lymphoma. After we confirm the diagnosis, we go to the workup. Baseline CBC, renal and liver function. There is no tumor marker for esophageal cancer. CT scan of the chest and abdomen with contrast. PET CT scan, especially for metastatic disease and local advanced disease. Bronchoscopy for any tumor at or above the carina. Flexible laryngoscopy, this is specifically for cervical cancer, for cervical esophageal squamous cell carcinoma. Diagnostic laparoscopy only for selected cases. Enteric tube for feeding. Treatment. The curative intent treatment is surgery or esophagectomy. Esophagectomy is performed for tumors located more than 5 centimeters from cricopharyngeus. Cervical and cervicothoracic cancer located less than 5 centimeters from the cricopharyngeus treated with definitive chemoradiation, similar to head and neck cancer, but not with surgery. Another method of treatment is chemoradiation, which could be given before surgery, preoperative, or after surgery, postoperative, or adjuvant. Chemotherapy and immune therapy, either given perioperative, before and after surgery, or postoperative, adjuvant, or of course, in case of metastatic disease, it is palliative as part of the best supportive care. Treatment of cervical esophageal carcinoma, which is squamous cell carcinoma. As I said before, it is managed similar to squamous cell carcinoma of the head and neck with definitive chemoradiation. The cervical and cervicothoracic cancer located less than 5 centimeters from the cricopharyngeus. Again, the treatment is definitive chemoradiation, not surgery, not surgery. Thoracic or abdominothoracic. There are two kinds, either squamous cell carcinoma or adenocarcinoma. So let's discuss first the squamous cell carcinoma of the esophagus. This is the TNM staging. For stage 1 to 3 and some of stage 4A, that means squamous cell carcinoma of the esophagus without distant metastasis. This is locally advanced disease or metastasis to multiple lymph nodes, regional lymph nodes. So this is except tumor that invades aorta, vertebral bodies, or airway. That's a T4B, or of course unresectable lymph nodes, N3, which is more than seven or more lymph nodes. So for this kind of disease, if it is an early stage and the patient is medically fit for surgery, for esophagectomy, the best treatment is endoscopic resection for very small tumors, like a T1, or ablation, or of course esophagectomy. R0, remember, R0 means surgical margins are negative. And those we could just observe them with or surveillance. For R1, R1 means microscopic margins, cancer at the margin but microscopically. They should receive concurrent chemoradiation after surgery. Or R2, this is a macroscopic disease or residual or grossly residual disease. We treat them either with chemoradiation or if the disease is too advanced, only palliation. Again, the same stages, but a little bit more advanced, locally advanced. Those we treat them with preoperative chemoradiation, assuming that they're medically fit for surgery. So medically fit. So being medically fit is a key for treatment of esophageal cancer. Preoperative chemoradiation, and then reevaluate with PET-CT and EGD. If there is no evidence of disease or maybe some persistent disease, you can go ahead with the esophagectomy, or you can just keep an eye on them. If everything is negative, no disease left behind, it could happen with chemoradiation. You find no residual disease, you can just monitor them. Of course, if disease is grossly persistent, residual disease or progressive disease with metastasis, palliation. Comfort. For patients who received chemotherapy and radiation prior to surgery and able to undergo esophagectomy and we found some residual disease, those patients nowadays we do give them non-chemotherapy, immune therapy, checkpoint inhibitor, PD-1 inhibitor, nivolumab, or Opdivo. This is a new recommendation, which is the adjuvant therapy for esophageal cancer after chemoradiation resection. They benefit from adjuvant treatment. Locally advanced disease, a T4B, remember, said a tumor that invades the aorta, vertebral body, or airways, or unresectable multiple lymph nodes, N3. Those patients, if they are medically fit for surgery, we do treat them with definitive chemoradiation or chemotherapy alone, and then reevaluate with PET, CT, and EGD. Few of them may end up having esophagectomy if they have remarkable response to the treatment, and or some of them they may not have, they may not respond, and those patients we just give them palliation. But if they're able to go with esophagectomy, then we can just observe them. This is not a typical scenario, but it could happen. For a stage, for the same stage 1 to 3 or 4A without distant metastasis, but if they are medically not candidate for surgery, non-surgical candidates, if it's early stage, endoscopic resection, ablation, local disease, definitive chemoradiation, radiation only, best supportive care. For advanced disease, including distant metastasis, if those patient has good performance status, ECOG stands for Eastern Cooperative Oncology Group. This is a scale for the performance status of the patient. It goes from 0 to 4, 0 asymptomatic, ECOG 1, some symptoms, 2, more than 50% active up and around, 3, less than 50% being active, 4, bedridden. So ECOG of less than 2 or less, we should check for biomarkers, MSI, MMR, BDL1, and even we may consider doing next generation sequencing, looking for non-chemotherapy regimen that they could handle, because they may benefit from this therapy or even chemotherapy, but we check for those first to see if there is any non-chemotherapy options, immune therapy, for example. For patients with ECOG score of more than 3 or more, that means they're more than 50% in the bed using a wheelchair. Those we treat them with supportive care, do not subject them to chemotherapy. Same staging to squamous cell carcinoma, very much similar actually. Same thing, same stage, 2 to 3, no distant metastasis. Again, the treatment is very much very similar. Medically fit for surgery, endoscopic resection, ablation, esophagectomy. Local advanced disease, medically fit. We give them chemotherapy and radiation. This is preferred concurrent chemotherapy, and usually we use Taxol, carboplatin during with radiation therapy. Or you could treat them with just definitive chemoradiation without surgery. If they receive chemotherapy, we do esophagectomy and then chemotherapy again. Same thing. If the patient receive chemotherapy, and then if the patient receive chemoradiation therapy, able to undergo esophagectomy, found to have residual disease, we give them immune therapy, checkpoint inhibitor, non-chemotherapy drugs, nivolumab or Opdivo, the drug of choice. Again, for locally advanced disease, fit for surgery, definitive chemoradiation or chemo, reevaluate with CT, PET, EGD, persistent disease, esophagectomy, no disease after esophagectomy, surveillance, metastatic disease, supportive care, or palliative. Advanced disease, same scenario like squamous cell carcinoma. Metastatic esophageal squamous or adeno. Basically, this is the chemotherapy regimen if you're interested. This cartoon just summarizes what we went through. So for local regional stage 1 to 3, no distant metastasis, any esophageal cancer should be discussed in a multidisciplinary meeting, including medical oncologist, radiation oncologist, surgeon, and dietitian. Discuss nutrition asset because nutrition is the key for any successful treatment. So, if the patient is found to be medically fit and the tumor is resectable and it is more than 5 centimeters from cricopharyngeus, surgery is a goal, either done upfront, followed by chemoradiation, or chemo alone, or, or chemo plus radiation after surgery for this group of patients. On the other hand, if the tumor is locally advanced, invading neighborhood structures, unresectable, or the patient is medically unfit for surgery, those patients, we treat them with chemotherapy or chemoradiation. It is case by case. If the cancer metastasized uh, outside the chest, distant metastasis, the treatment is palliative and it is best supportive care. Take home message. Squamous cell carcinoma is the most common type of esophageal cancer. Adenocarcinoma incidence is rising, especially in the Western countries. For metastatic disease, remember to check for biomarkers, MMR, mismatch repair, proteins, MSI, and PD-L1 program, cell death status, to see if the patient could benefit from immune therapy and non-chemotherapy. HER2 for adenocarcinoma, patient may benefit from targeted agent, trastuzumab. Take home message number 2. Cervical esophageal cancer, it is usually squamous cell carcinoma. No surgery for this disease, should be treated with concurrent chemoradiation similar to head and neck cancer. Accurate staging is very important in the management. So with accurate staging, we can identify early stage disease, which could be treated with surgery or endoscopic therapy. Non-surgical cases treated with definitive chemoradiation. Local advanced disease treated with combined modality therapy, typically chemotherapy, radiation, and surgery in different sequences. Now, move to gastric cancer. Stomach cancer or gastric cancer is high in Japan, Korea, Venezuela, Chile. The incidence of stomach cancer is declining rapidly worldwide. This may be due to recognition of certain risk factors, treatment of H. pylori, diagnosis and treatment of H. pylori, dietary and environmental factors which you could avoid, and of course the use of refrigerators had a big benefit and role in decreasing the incidence of uh, gastric cancer due to two causes. Number one, reduce salt-based preserved food. Unfortunately, we have still the habit of using a lot of salt-based preserved food, تركين وملوحة. Also, refrigerator prevent bacterial and fungal contamination. Unfortunately, this is also, we are not good for this because of the power outage. But anyway, fresh food source of as an antioxidant. But recently it has been noticed there is rising of stomach cancer, especially in young population for unclear reasons. Symptoms of gastric cancer: weight loss, abdominal pain, nausea, dysphagia, melena with iron deficiency anemia, early satiety, ulcer type pain. On physical exam, the patient may have hepatomegaly, ascites, virtual nodes, which is an enlarged left supraclavicular lymph node, Irish node, enlarged left anterior axillary lymph node, Sister Mary Joseph nodule or sign, which is a periumbilical nodule, Krukenberg tumor, drop metastasis into the ovaries, or drop metastasis in the cul-de-sac, which is a Plummer shelf sign. There are some paraneoplastic for the gastric cancer, microangiopathic hemolytic anemia, membranous nephropathy, Trousseau syndrome, superficial phlebitis, poly, polyarthritis nodosa, dermatologic presentation, eruption of diffuse seborrheic keratosis, sign of lesser trilate, acanthosis nigricans, soft, dark, pigmented patches on skin folds. Risk factor for gastric cancer: H. pylori is a risk. Family history: there are three kinds of hereditary gastric cancer. Hereditary diffuse gastric cancer, characterized by CDH1 gene mutation, gastric adenocarcinoma, and proximal polyposis of the stomach. Familial intestinal gastric cancer, again, salt preserved food, مليحة وتركين. Low vegetable and fruit, N-nitroso compounds used to preserve meat. These are all risk factors for stomach cancer. Obesity is a risk. Smoking, alcohol, Epstein-Barr virus infection, working in coal mining. There are some precancerous conditions for the two types of cancer: intestinal type cancer, intestinal type gastric cancer, chronic H. pylori, pernicious anemia, and high salt diet lead to chronic atrophic gastritis and intestinal metaplasia. That's a precancerous. Gastric atrophy and resection lead to hypochlorhydria. And atrophic gastritis, which is an autoimmune disease, also leads to hypochlorhydria. This leads to hypergastrinemia, which may cause increased gastric pH, and that leads to bacterial colonization, which convert dietary nitrates into N-nitroso compounds considered carcinogenic. Intestinal metaplasia and dysplasia caused by H. pylori infection or bile reflux is a risk factor for, or actually considered precancerous for gastric cancer. For the other type, which is diffuse type cancer, there is no precancerous lesions. This is the, if we recall, this is the hereditary type of stomach cancer. Diagnosis: EGD is the gold standard to diagnose stomach cancer. You can find the tumor and take a biopsy, of course. Again, the tumor may look like a friable ulcerated mass or just a gastric ulcer, or the EGD could be normal in case of linitis plastica. In this case, barium X-rays could be beneficial. Again, we like our endoscopist to do a deep resection, a deep resection, yes, biopsy, essentially for accurate staging. So we can tell the depth of the tumor in the wall of the stomach, and that is very much needed for the treatment, especially for early stage cancer. Obtain blood counts, kidney and liver function, CT scan with contrast, EUS, endoscopic ultrasound for diagnosis, and staging for the early stage cancer. It's very good for the depth of the invasion of the tumor into the stomach wall. PET scan for metastatic. Clinical classification of stomach cancer: superficial gastric cancer, focal, fungating or polypoid, infiltrative, which is linitis plastica. Pathology: adenocarcinoma. 95% of stomach cancer is adenocarcinoma, and the most common adenocarcinoma is intestinal type. Diffuse gastric cancer, this is an inherited type associated with a CDH1 gene mutation. For adenocarcinoma, especially metastatic, we perform MMR, mismatch repair, proteins, MSI status, PD-L1 status, with or without next generation sequencing to lead us for a non-chemotherapy options. For all metastatic stomach cancer, we need to know the status of HER2 for therapeutic reasons. We could use anti-HER2 along with chemotherapy. Other pathology: lymphoma, sarcoma, leiomyosarcoma, or gastrointestinal stromal tumor, GIST tumor, or carcinoid. Staging: here is the staging, pathologic and clinical staging. Treatment: again, the curative intent treatment for stomach cancer is surgery, gastrectomy with lymph node dissection. Subtotal gastrectomy preferred over total gastrectomy. Basically, they are comparable in regard to the survival, and of course, lower morbidity with the subtotal gastrectomy compared to the total gastrectomy. We like to see a 5 centimeter proximal and distal resection margins, negative resection margins. Another method of treatment is chemoradiation, which could be given before surgery, preoperative, post-operative, adjuvant. For chemotherapy without radiation, that's typically given perioperatively before and after surgery, or post-operative adjuvant, or it could be palliative for best supportive care. Immunotherapy, typically given as part of the palliative treatment or best supportive care. These are the reconstruction procedures after the gastrectomy. Extent of lymphadenectomy. This is a very hot area for discussion and debate. regional lymphatics of the stomach or perigastric lymph nodes, uh, paracardial, paragastric, and parabilaric regional lymph nodes. Dissection of those is called D1. But dissection of retroperitoneal and lymph nodes along named vessels like celiac trunk, left gastric artery, hepatic artery, splenic hilum. This is called D2, a little bit away from the stomach. This is done in mainly in Japan and done by very experienced surgeons. The goal is to remove at least 15 lymph nodes for adequate lymph node dissection. So the surgery with few lymph node removal is inferior to dissecting 15 or more. If you dissect lymph nodes in the retroperitoneum and along the named vessels, the outcome is better. So treatment based on the stage and extent of disease. Non-surgical stomach cancer is treated with endoscopic resection and then surveillance. For medically fit patients with early stage disease, still we could do endoscopic resection, and then surveillance if they have very early stage disease like a T1. Gastrectomy, if it's done with an R0, remember R0, negative surgical margin, surveillance is fine. With an R1 or R2, residual disease microscopic or macroscopic, we give them chemoradiation after. For local regional disease, medically fit, potentially resectable, we go to surgery, gastrectomy, or perioperative chemotherapy actually is preferred if you give chemotherapy before surgery for local regional disease. It is preferable not to take the patient to surgery, give them chemotherapy first, or actually even chemo and radiation, then restage with a PET CT scan, and then surgery, which is subtotal gastrectomy. And if R0, negative surgical margins, surveillance. If R1 or R2, concurrent chemoradiation. And the chemo typically is a 5-FU IV or the oral form of 5-FU, which is capecitabine or Xeloda, followed by chemoradiation, followed by chemo, like a standardish chemoradiation chemo. Of course, for patients with progressive disease. For locally advanced or metastatic stomach cancer, if they're medically fit, the disease is unresectable, consider laparoscopy first to make sure it is truly unresectable. If it is, then no surgery, take them to chemo and give them chemo and radiation or chemotherapy only, reevaluate with PET CT scan, and then gastrectomy if feasible. Non-surgical patients with performance status 2 or less. Again, we look for non-chemotherapy options for immune therapy or targeted therapy. We check for HER2. If tumor overexpress HER2, we treat them with trastuzumab based therapy. PD-L1 for patient with PD-L1 status, MSI or even doing NGS next generation sequencing, looking for targeted therapy. If not, the options are chemoradiation or systemic chemotherapy or best supportive care. For patients with poor performance status, best supportive care. Stage 4, of course, best supportive care. These are the chemotherapy regimens if interested. This cartoon summarize what we went through for the stomach cancer. So after surgery, here is the outcome. 4 scenarios after surgery. R0, negative resection margin. If it's a T1, early stage superficial disease, observe, done. Surgery and done. If the T2 went through the wall of the stomach to the muscle, then observe that it's fine, or chemoradiation or chemo if given before surgery. If the tumor went through the wall or reached lymph nodes, radiation, chemoradiation. If the margin is microscopically positive, then radiation or chemoradiation. If the margin is grossly positive, residual disease. Of course, again, radiation, chemoradiation, or even supportive care. If there is metastasis, distant metastasis, then palliative or best supportive care. Take home message: early stage stomach cancer with a diameter 2 millimeter or less, small tumor, lymph node negative, well differentiated adenocarcinoma, endoscopic resection should be fine. No gastrectomy, just endoscopic resection, leave the stomach. If you suspect lymph nodes involvement, then the best treatment is gastrectomy with lymph node dissection. Remember, D1 fine, but D2 is preferable, but this needs special centers and very experienced surgeons. For positive lymph nodes on or more than T2, that tumor invades through the wall, even after gastrectomy, we give them adjuvant chemotherapy, and typically is given like a sandwich: chemotherapy, chemoradiation, and then chemotherapy. And the chemotherapy typically is 5FU, which is an old type of chemotherapy. GE junction and proximal gastric cancer or cancer of the cardia treated as esophageal cancer. We follow the steps for the esophageal cancer. And for those, we use a chemoradiation preoperatively before surgery. Again, metastatic disease, all the time remember to check for MMR, mismatch repair, and MSI, PD-L1, programmed cell death. And you also may consider doing next generation sequencing, trying to find non-chemotherapy treatment, targeted therapy. Of course, all stomach cancer, metastatic, we should check for HER2 for therapeutic reasons. Now, let's move to the third part of upper GI cancer, which is pancreatic cancer. When we say pancreatic cancer here, we mean adenocarcinoma of the pancreas, the exocrine gland cancer, because the pancreas has other type of cells which could become cancerous too. Here we mean adenocarcinoma, exocrine gland cancer. Presentation: symptoms: anorexia, painless jaundice, very typical for pancreatic cancer as a silent killer. Weight loss, new onset diabetes, mid-back pain due to invasion of the tumor into the splanchnic plexus, which includes sensory and sympathetic nerves, nausea and vomiting. These are late-stage disease when the tumor invades into the duodenum and gastric outlet. Staturia or change in bowel habits. Signs: there are some signs very specific for pancreatic cancer. Palpable gallbladder, Coffesier sign, migratory superficial phlebitis, Trousseau syndrome, ascites, enlarged left supraclavicular lymph node, Virchow node, Periumbilical mass, Sister Mary Joseph node, Schmidt's triad due to hypersecretion of lipase, causing pancreatic panniculitis, eosinophilia, and polyarthralgia. Diagnosis: CT scan, especially spiral CT scan, plays a very important role to assess vascular encasement. And with CT scan, we could do CT guided biopsy. EUS is a new modality, very helpful in case of pancreatic cancer. Endoscopic ultrasound or EUS has a very high accuracy, especially for the pancreatic cancer, for the primary tumor itself. The accuracy is 85 to 90%. For the lymph node, it's 50 to 70%. Could go as high as 90% if it's combined with FNA. And also very good to evaluate portal vein and SMV involvement. It is less helpful for SMA. Of course, with the CT scan and EUS, we obtain biopsy to confirm the diagnosis for pathologic diagnosis. MRC and ERCP, these are complementary to the CT scan. During ERCP, we could obtain also biopsy or cytology. PET scan, diagnostic laparoscopy in certain selected cases. Remember, CA19-9 is not a diagnostic test, but it is a prognostic tumor marker. Very high CA19-9, 1,000 or more, carries a poor prognosis. Pathology. 95% of pancreatic cancer is adenocarcinoma, arise from the exocrine gland ductal system. So when we talk about pancreatic cancer, by default, we mean adenocarcinoma. Other type is acinar carcinoma, mucinous cystic neoplasm, and 2/3 of pancreatic cancer occurs in the pancreatic head. Treatment. Before we talk about treatment and discuss options with the patient, we should do staging and evaluate for resectability, because the only curative treatment or a treatment that improves survival is successful surgical resection, which is a Whipple procedure. So we should evaluate thoroughly and carefully for resectability. This is done by spiral CT, endoscopic ultrasound, sometimes laparoscopy, diagnostic laparoscopy. So based on those tests, we find a tumor that is resectable, or maybe borderline potentially resectable, or not resectable, or maybe metastatic. The first step in treatment, if there is a jaundice, we should relieve the jaundice by stenting before we start treatment. The surgical treatment for pancreatic cancer is very standard. It is Whipple procedure. Chemotherapy and concurrent chemoradiation are used before or after the surgery, or even without surgery as palliative treatment. Targeted therapy the same, and immune therapy or a checkpoint inhibitor. All these are, anything other than surgery is considered palliative. So if the tumor is resectable, the procedure of choice is Whipple procedure. Remember, this is very important. Remember, All patients, including T1, the early stage of pancreatic cancer, those not received chemotherapy before surgery, all of them should receive adjuvant chemotherapy if we try to improve their disease-free survival and survival. This is for everyone except a small subset. Those are patients with early stage T1 well differentiated acinar tumor. We may omit the adjuvant chemotherapy. Chemotherapy for fit patients is very tough chemotherapy. It's called FOLFIRINOX, and especially for patients with BRCA mutation. Less fit patients, we use gemcitabine and capecitabine. Unresectable pancreatic cancer. We define unresectability if the tumor is associated with extensive periaortic lymph nodes or large lymph nodes beyond the peripancreatic tissues. Direct involvement of SMA, inferior vena cava, aorta, celiac axis, hepatic artery by the tumor. Thrombosis or occlusion of SMV portal vein, also considered unresectability features. Those patients we do treat with a new adjuvant or preoperative chemo or chemoradiation, then re-evaluate for resectability. Whipple procedure if feasible. Any role for preoperative new adjuvant therapy? This is an area of debate, but the NCCN, the National Comprehensive Cancer Network, recommend preoperative or neoadjuvant therapy for high-risk, potentially resectable or borderline pancreatic cancer. Imaging concerning findings not clear for resectability. Very elevated CA19-9, large primary, large regional lymph nodes, excessive weight loss, extreme pain. Those patients may be treated with new adjuvant preoperative therapy and the regimen not well defined. It could be chemotherapy followed by chemoradiation or chemoradiation, then Whipple procedure, then adjuvant therapy. The preferable regimen is a very rough regimen, which is FOLFIRINOX, but also could use doublet, which is gemcitabine and Abraxane, followed by surgery, Whipple procedure, and then adjuvant chemoradiation. Metastatic disease, all pancreatic cancer should be counseled and tested for G mutation, BRCA, and BALB2 G mutation. Treatment options may include combination chemotherapy listed here for patients with BRCA or BALB G mutation. The treatment is platinum based, followed by PARP inhibitor like olaparib. Also, metastatic patients treated with second line could be treated with second line therapy if they have deficient MMR or MSI high, and we treat them with immunotherapy, checkpoint inhibitor, Keytruda. Take home message: because surgery is the only curative treatment for non-metastatic pancreatic cancer, all patients with non-metastatic pancreatic cancer should undergo a thorough evaluation and diagnostic procedures procedures to determine resectability. This is done by spiral CT scan, EUS, endoscopic ultrasound, laparoscopy, and sometimes PET scan. If the patient is able to undergo resection, Whipple procedure, and not received preoperative or neoadjuvant chemotherapy, should be offered adjuvant chemotherapy for 6 months. With an exception, patients with well-differentiated acinar T1 tumor, well-differentiated small tumors. Otherwise, everyone with non-metastatic pancreatic cancer not received chemotherapy before surgery and able to undergo Whipple procedure should be treated with adjuvant chemotherapy for 6 months. Metastatic disease. Those patients should be counseled and tested for BRCA, and if mutated, may benefit from PARP inhibitor. Also assess those patients or the tumors for MMR. If deficient, MMR or MSI high may benefit from immune therapy, checkpoint inhibitor. Thank you much.